see what happens. I just don't know if
yeah,
I'll be
no,
able to.
yeah, it's doing it. So
Okay, we'll see what happens. Can't promise that we'll be able to get to this file later, but at least we can try.
okay. And apologies for not having video, but my bandwidth here in the sticks, um, it'll kick me out of this if I turn on the camera. So
No problem.
so
I'm probably going to shut off my video as soon as we officially start for the same reason, because that's what causes the bandwidth problems on Zoom.
yeah. But in terms of those other videos, like the camp lectures and stuff like that, is that what you were talking about?
Mm-hmm.
I think a lot of those are still available on YouTube.
They are on YouTube. Okay, I wasn't sure.
Yeah. I mean, if anybody wants to, just email me and I can look up the link. But the foundation has stored a whole bunch of them on YouTube. So
very nice. Thank you, Ray.
sure.
Yeah, I was talking about how Al Bartlett's lecture was one of my,
the
one that stands out the most to me from my delegate year. And I enjoyed it so much, I actually contacted camp afterwards and asked if they could send me a VHS tape of it, which they did. And I still have that tape, but I know it's online as well, because I know that Andy or somebody reshared it this summer, because, you know, it's relevant, of course, to the pandemic.
It looks like we maybe should start in about 1 minute.
Okay. And I will mute myself and turn off my video when you get started, just to conserve bandwidth. But I'll keep manning the waiting room. So if people continue to trickle in, which is
go from the practice of child and adolescent psychiatry, and I'm still an adjunct professor of psychiatry at the University of Arkansas, and I was a delegate from Arkansas in 1967, and was recounting to some of the people I was visiting with that I have no idea how we were selected to be delegates in 1967, or what criteria were used, or who did the selecting, but I had a good time. The topic that I have chosen here is the hard impacts of neurological soft signs. And this is about children, basically. And when we talk about doctoring on children, we're usually talking about detecting signs or detecting symptoms, symptoms being the subjective experiences that are reported by the children or by their families, and signs being those things that you can observe, either with instruments or with your own senses. And when we talk about neurological signs, we're usually talking about signs that will either help you pin down one side of the body, lateralizing signs, or localizing signs that will help you pin it down even further to a particular place. But when we talk about soft signs, that means they're neither localizing nor lateralizing, so they don't pin it down any further. And these are generally considered to be partly developmental, if not wholly developmental in origin, and they're kind of mysterious, but they do reflect something that's important about children. And historically, there's two scientists that have studied these more than anybody else. One of them is a pediatrician in Baltimore named Martha Dinkla, and the other is my personal mentor, John Peters, the late John Peters. And so I have a natural interest in it. We usually study these soft signs of neurological development in children from ages 5 to 13 because it's too variable and too unpredictable and not very useful to study them in younger children. And among adults, you can more or less assume, and this would include yourselves, that somewhere in the neighborhood of 1 out of every 20 of intact functional adults is probably going to have one neurological soft sign somewhere. Most of us have survived those, and they haven't really made any huge impact in our lives, but they may have made some impact, and we'll talk about what those impacts are. Um, so just to give you an example, the first one, and this is one when you're doing the exam, it ordinarily requires that you have the child stand up, put hands out in front like this. Can you see me? Hands straight out in front, fingers spread, looking straight ahead. And then you have the child close her eyes or his eyes, and you stand behind the child and begin to move the head a little bit left to right in broader and broader movements. And what you see, if everything is more or less ordinary, what you see is that there's either a little bit of arm drop or no arm drop at all. But as it becomes less and less typical, there's a little arm drop, arm spread, and the trunk begins to get involved and move. And there's significant arm drop and arm spread and trunk movement. And the basis for this is that when the baby's just a few days old, when the arm moves that way, the head turns. And that's sort of the neural substrate on which eye-hand coordination begins to develop. And if that doesn't happen, you don't start to have those movements developing together, and you really can't develop eye-hand coordination. But that should be gone more or less within the first year or two of life. And if you hit school age and you're still doing it, then you begin to have trouble. So suppose you're trying to play softball with the other kids, and you're running to catch the ball, and you're out in the field, and your arm goes out to try to catch the ball, and your head turns. So suddenly you can't watch the ball. So you don't see the ball into your glove or into your hand. So you can't learn to catch the ball. So you're going to be the last one chosen if that persists when you choose up sides. And furthermore, you're going to be lacking an important social skill for your childhood unless somebody shows you another way to do it. So this residual tonic neck reflex needs to be overcome somehow. And that is a neurological soft sign that has definite social implications and causes you trouble in your life if it persists. And it's a good example. And it's a little bit complex to assess because you have to be able to watch the child, and you have to, and they're doing this, and you can see it asymmetrically, you can see it symmetrically, and that's a little more sophisticated piece of the assessment, but we don't need to go there right now. So the skill that's most obviously impaired if your tonic neck reflex persists is catching a ball. Okay. Then another neurological soft sign is tapping. So we start out, and you can test this on yourself. We start out with palms up, resting, and then your dominant hand first, and you tap, 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 tap. And you should be able to do it fairly smoothly and fairly rapidly. And you should be able to do it the same thing with the other hand. And you should be able to do it without appearing as if your fingers are glued together or trying to be glued together. And you should be able to do it with one hand without the other moving. And should be able to do it fairly smoothly. you should be able to do it without the grip being like a lobster claw. That pincher grip, if that's too natural to you, and a lot of us struggle with that, but that pincher grip really gets in the way of our pencil and crayon prehension and causes difficulties learning to write. And so that's one of the problems that's caused if your tap grip is not as it should be. So you can check that out for yourself. Then the other thing that we look for is for associated movements. When we are doing this, we ought to be able to do it with one hand alone and the other hand not be involved. And that should go both ways. So that, now, why would that make any difference? If I'm a kindergarten child and I'm holding a piece of paper in my left hand and it has a circle drawn on it, and my task is to cut out the circle, and I have scissors in my right hand, and I'm holding the paper, and I have associated movements so that the left hand tends to want to do what the right hand's doing, so that if my right hand opens up, my left hand wants to open up. I can't even hold the paper right. So I can't get a firm grip on the paper, so that the paper slips a little bit each time my scissor hand opens up. So what kind of a incompetent kindergarten child am I? I can't hold the paper to cut it competently. I can't even cut out a circle. That is a basic kindergarten skill. So this minor neurological soft sign of associated movements begins to have a major impact when you're trying to do something that the teacher is asking you to do and you just can't do it. So once again, now in a more sophisticated challenge, as you get a little older, and mama wants you to take piano lessons so that your left hand and your right hand have different tasks assigned after you've been playing for a few months. And the same thing's true if you're trying to play the guitar. You're trying to make a chord with the left hand and pick with the right. And these are a challenge if you have the associated movements. So doing different tasks deliberately and in a coordinated way with the different hands is again a challenge. Okay. So the next soft sign that we test for typically is right-left confusion. We usually ask the child to hold up her right hand. We usually ask the child, which hand do you write with? Which foot do you kick the ball with? We usually ask the child to cover up one eye and look at me. So we got to try to get a sense of which the dominant hand, foot, and eye are with the given child. And by mid first grade or late first grade, every child should be pretty well settled on their own dominant hand, foot, and eye, but they also should be able to tell you which is which for themselves. And by age 8.5, the child ought to be able to tell you, if you're doing the examining, the child ought to be able to tell you which is your right hand. They ought to be able to do that 180-degree mental rotation and tell you which is your right hand and right foot. And so it could be a problem if not. Now, why is it important to be able to tell your own right from left? Well, we have to learn how to cross the street safely. And we learn to look to the left, look to the right, and look to the left again. That's how I learned. And that's a solid way to learn. And that by itself is a strong enough reason to be able to reliably identify your own right and left hand. Because it's a big safety issue. Okay. Now I'm gonna introduce a big bad word here. The big bad word is dysdiadochokinesis. I could never find anybody in any basic science or neurology who could actually tell me what diadochokinesis means. But dysdiadochokinesis is when it's not right. Diadochokinesis is the ability to perform rapid alternating movements. It is a cerebellar function that we know. So we test it usually by asking someone to slap their knees like that, or slap one hand rapidly like this, and then get faster and faster. We ask them to do it with a smooth rhythm and with increasing speed. And if they can do it for several beats, then that's great. In terms of the skills of childhood, this is the kind of skill that's involved in learning to jump rope. It's the kind of skill that's involved in learning to do the hand jive, or to do the girls' games like Oh Mary Mac, Mac, Mac. And I was unable to think of any traditional boys' games that do the same skills other than, jumping rope in the boxing gym. But perhaps somebody in the audience will be able to think of something. But the inability to be able to do rapid alternating movements like that is a cerebellar dysfunction, and it's called dysdiadochokinesis, and it's dysdiadochokinesis, if you ever need to spell that. The ability to maintain your balance in a statutory or standing capacity is a soft sign. So we usually ask a child to stand on one foot and then the other foot, starting with the dominant foot and then the non-dominant foot. And we ask the child to kick as if they're kicking a kickball or a soccer ball a very short distance. And if we don't specify a very short distance, we're going to get children flinging themselves all over our offices. And it's just totally not satisfactory. And we will have children that cannot stay still on the dominant foot even for a couple of seconds. And that is clearly a neurological soft sign. It's a sign of poor body control and poor coordination. It is a mark of the same kind of difficulties as we've been talking about before, the same sort of difficulties. We usually, as part of this assessment, also ask the child to write a little something. If it's a child in kindergarten, first grade, or even second grade, I usually ask them to write their full names. Grades 3 and 4, I will ask them to write, "That boy saw a dog," or "That girl saw a dog." In grade 6 and up, I will ask them to write, "That question was about the Constitution." I'm mainly interested in how they attack the challenge. And if they have any sort of logic to it. Now, this assessment is part of a comprehensive evaluation. It's a way of assessing the child's motor development. It assesses gross motor and fine motor development and coordination in a mixed way. It is not intended to be comprehensive, but it gives you a lot of clues, and it gives you clues about things that make a difference in a child's life. A child who has neurological soft signs at age 7 has a very high probability of having significant social anxiety as a teenager. It is not difficult to imagine the pathway to that happening. If you are a child who has limited sports skills and who has limited abilities to do what are considered to be the minimum competences of school and of childhood. I mean, if you can't do the things that children are expected to do, and you struggle to do just the basic things, then you're going to feel incompetent. You're going to feel like the pee-pee boy. You're going to feel like, I can't do it. Why am I even trying? So life is going to be a struggle. And why would it be unusual for you to have social anxiety and to struggle with how other people think about you and how you're perceived and how you perceive yourself? It is also true that a lot of these kids have other developmental issues as well. A lot of them have poor attention spans. A lot of them have other learning disabilities. A lot of them have enough of these neurological soft signs that they will qualify as having developmental coordination disorder on the basis of these signs. A lot of them have poorly developed social skills. A lot of them have specific learning disabilities. They'll have language skills that are very limited. They'll have general cognitive development that is impaired or iffy in some way. And so it's not unusual at all to see these developmental problems mixed with other developmental problems. And when you get those things mixed together, you also begin to see behavior issues. And it will be no surprise to anyone that when you see children with behavior problems, they also tend to have emotional problems because they're unhappy. Now, as we try to construct an approach to making these children do better, helping these children to do better, there are basically 3 things for which there's some evidence that they help. And these things are typically available to some extent in most areas, either in the medical structure or in a school structure. And those three things would be occupational therapy. And this is best accomplished by an occupational therapist who has specific training and experience in dealing with children's developmental issues. I'm going to step on the soapbox for a minute. There are a lot of occupational therapists out there who are interested in sensory issues and who have a belief system that says that sensory issues hold a key to the remedy for a lot of these problems. That may or may not be true, but the evidence that I've seen is pretty scanty. So if someone presents that to you, you want to ask for the evidence base for thinking so, and you want to ask for specifics and not just generalizations. So I don't want to throw the baby out with the bathwater, but I would like to have something solid on which to base it. But occupational therapists who have childhood training and who have specific training in the remedy for these kind of developmental issues can be worth their weight in gold. Physical therapists, similarly, can have the right kind of training and understandings and do a world of good for these kids, particularly those kids whose problems are associated with cerebral palsy and other more clearly diagnosable physical syndromes like that, all of which need to be looked for every time. And then the third kind of helper that needs to be considered is a specialist in adaptive PE. And they're scarce people, but again, they're often worth their weight in gold. And their skill sets can be exceptionally valuable. So we've got a group of kids who have non-localizing and non-lateralizing signs of neurodevelopmental delay and difficulty, and they're the kinds of things that can cause all sort of misery woes in childhood and complications in the other aspects of development. If your coordination is bad and your handwriting is bad and your ability to cut out a circle is bad and your ability to catch a ball is bad, then the chances are you're going to have social trouble and you're not going to be a happy camper and you're not going to like yourself very much. And all of these things tangle up together developmentally. And if we begin to make the physical problems a part of the remedial plan, then we can often have a favorable impact on the rest of it. Okay, so that's the essence, and I'm glad to entertain any questions or comments.
I was going to say, I think what really interests me about this sometimes is because of the way these things appear to other children, is the stigma that gets attached to kids. You know, I mean, the old infamous, you throw like a girl, you know, or just, you know, being bad at athletics or just awkward, I guess may be the term. You know, you get picked on or made fun of by other kids, which, I mean, you know, can make situations even worse.
That's good. And throw like a girl is a good example, because there's also you run like a girl. And y'all got any comments on that? Nobody's saying anything about that, huh?
The thing that I would add to that is that because maybe somebody gets made fun of or, you know, stigmatized for stuff, there can also be a good side to it. You get pushed into something else. I mean, I was one of those awkward kids. I was not good at sports and stuff. I was always the one who was the referee or the umpire. But then because I wasn't good at sports or stuff, even though I tried, I ended up concentrating on the academic side of things. And so it pushed me to develop those skills instead of skills that, you know, wouldn't have served me as well, maybe.
That's interesting. Anybody else throw like a girl? I had that issued as a challenge one time in one of my group therapies, and it was perhaps the most successful challenge ever, because the girl involved quite literally threw the dodgeball and knocked down everybody else in the group. It was a great demonstration. I wish I could stage it and make it happen on purpose.
I do have one question about this, because I just wondered. I mean, this may be a stupid question. I don't know. With certain of these things, are there ways to train yourself out of them? You know, like or to exercise or I don't know what I'm saying. You know.
Well, I think I do know what you're saying. Yes, there are exercises and techniques that you can practice that actually make a difference. For instance, catching a ball. We gave that example earlier. The kids who struggle the most to learn to catch a ball are the ones that reach out to catch the ball. The kids that are the most successful at it are the ones that position their bodies directly in the path of the ball where it's coming toward their chest. So that's a technique you can learn, to have the ball coming directly toward your chest so that you're catching it two-handed straight in. And you practice that instead of reaching out for it, because reaching out for it is not going to work if you have tonic neck reflex. But two-handed positioning yourself to catch it straight in is much more likely to be successful. And that's something you can learn, like from an OT or from an adaptive PE teacher.
Right.
Make sense?
I'm sorry.
Go ahead.
I get a question, but it's out of ignorance. So beg your pardon for that. But when we talked about this lack of coordination hand-head, is it because there is a path in the brain that never gets to develop?
Well, the answer isn't clear, and it's probably different for different individuals. In some people's cases, it's probably the misdevelopment or the failure to develop adequate connections during the second trimester of pregnancy, for example. It's connectivity. In other cases, it's something different. And it's if you're really interested in this field, I think there's a ton of good dissertations to be written here. There's a whole bunch of interesting stuff to study on the neurodevelopmental pieces of this. And a lot of the study could be done non-invasively. I mean, people want to do the sexy studies with functional MRI and expensive techniques like that, but I think there are a lot of really interesting things you could do much more cheaply.
Okay, thank you.
On a sort of a side note, I don't know if this is connected or not. There was, we have a 76 alumni by the name of Rudy Tanzi, who is a big time researcher on doing Alzheimer's research. And one of the things he's talked about in some of his presentations is that he said, we don't always exercise our brain. And by that, he didn't mean like working on mental things, but he meant like, how many of you, always brush your teeth using the same hand and the same arm? How many of you always put on your pants the same way, the right leg before the left? And he said one of the things that he felt could help, exercise the brain and work out maybe some issues that might lead to dementia would be, make a point of doing things differently. Put your pants on using the left leg instead of the right leg. Try and brush your teeth with your left hand and your left arm instead of your right. I tried that the other morning and it was like, this is really difficult.
Yeah.
And so I don't know if there's any connection there or not, but like, I asked that question about exercising, and that's also something that comes to mind, is to try and maybe create different neuro pathways by doing something a little bit differently.
I agree. That's interesting. I don't know how it relates, but I agree that it's very interesting. It could relate. And of course, it immediately starts me thinking, if we have a group of people who are at risk neurologically because of this, are they also at risk in other ways neurologically? And could their neurological risk be reduced by just what you're saying, by increasing their neurological flexibility? I don't know. But it's cool to think about.
So I was just wondering, for clarification, the tests that you mentioned that are done on little kids, are those things that are kind of done automatically, or only if you notice that something seems to be off? And I guess I ask this as the new aunt to an almost 7-month-old, so I want to kind of make sure that she's developing, as she should.
Yeah, it depends on where you are. That's the honest truth. There are some institutions where they're automatically part of the evaluation, and other institutions where they're not. In my personal opinion, it ought to be. In my personal opinion, every kid that's kindergarten age and up ought to have this at least screened for. but you know, very few people have actually asked me for that opinion. So I think that if you look for those things, you're doing the world a service, because if you detect those problems when they're there, you can remedy the difficulties and have some happier and more functional children in the world. In the meantime, you can be on the lookout as your own family develop. You can be on the lookout. You don't want to get paranoid about every little thing, but you want to at least be aware if the children in your own family just don't seem to be able to do stuff, then try to identify some resources. Look for places where they could be screened for developmental coordination disorder. As I said, there's no point in doing it below age 5 because the norms are not well developed and there's hardly anyone that'll mess with it.
I apologize if you already answered this. Zoom keeps booting me, but do you know of any current research that's going on with causes of neurological soft signs?
Nope, I do not. But the DENCKLA, Dinkla, Martha Dinkla's probably a good source person to look up, and her pediatric group has been studying this. Another group that has looked at this not in the past couple of years, but in recent years, would be some of the people at Columbia have studied on it some, and if you Google Scholar neurological soft signs, you'll find some really interesting specific correlational research that involves schizophrenia and other particular conditions. So that's a pathway you can easily follow.
Awesome, thank you.
Mm-hmm. I don't want pressure anyone into talking just to be talking, but I will take another 2 minutes, and if you got something to say or ask, go for it.
Bye, everybody.
Thanks, Richard.
My pleasure.